Good morning, and thank you. I'd like to thank the organizers and John for inviting me today. It's a great honor and a pleasure to be here, and a little bit daunting. Speaking to surgeons and doctors is slightly different, but so if I'm nervous, you know why. Okay. I feel like a little bit of a fraud standing here talking about improving patient experience. I appreciate there's decades of patient experience in the audience. What I should really be asking is how can I improve patient experience? And hopefully there'll be an opportunity for that. But I'll talk about a little bit of the work that we've done in my small corner of Birmingham. And hopefully this will give us an opportunity to sort of discuss amongst ourselves and some of the excellent speakers we've got this morning to see how we can achieve an improvement in the service we provide to our patients. So I'll talk about a little bit about the background, the challenges we face, what we as service providers want, and what the patients want. We'll start off on a sort of positive. If you look at the service we provide for keratoconus in the UK compared to some of the other countries, we're doing reasonably well. Obviously better than some of the developing countries because we've got a fantastic access to contact lens services, equipment, technology, transplant, donor tissue, etc. But also some of the developed countries. For example, the States only had collagen cross-linking approved 2 years ago, and we've been doing that for over a decade here in Europe. So we've got all of that, and in the UK especially, we've got good sensory support service, and I'm sure you'll hear a bit more about that later on from our other speakers. So I tried to look and see what evidence there is for improved patient experience in keratoconus, and surprisingly, I couldn't find anything. But I came across the NHS Confederation, which is an independent body. It encompasses about 95% of NHS organizations, and there's a document on improving patient experience there. And what they state is we've got to be clear about our aims, which is pretty obvious. It talks about understanding what is valuable to patients, looking through their eyes, as they put it, redesigning our care, and getting the staff that work in our hospitals to own the system. Okay. And again, stating the obvious, they say improving experience is complex. It starts at the point of contact, so the point at which new patients are diagnosed and referred to the hospital. And it also states that having an efficient process and good clinical outcomes are key, but they're not enough. So an efficient process where your appointment's on time, you come in, you have your appointment in your home within 10-15 minutes is efficient. But if you don't get your diagnosis, your treatment, and the information, then that's no good. Good clinical outcomes. If you achieve 6/6 vision after a transplant, that's great. But if we could have prevented you having a transplant and kept your 6/6 vision, that would have been even better. So the right care at the right time in the right manner. Now that sounds like a politician, but actually there's some truth in it. So again, as I said, I tried to look for evidence, and there was no evidence out there. Funny, there's lots on cataracts and hips and joints and things like that, but very little on keratoconus. I was looking to see if there's evidence of improved experience, evidence of good clinical practice, and evidence where the services are cost-effective. Now, there are lots of units around the country, Moorfields and Liverpool, Sheffield, that have some fantastic clinical services. But there was nothing that I could take and replicate in my unit due to the various pressures that we face. We all know that the constraints that we face in the health service are mainly due to staffing. There's not enough doctors, optometrists, technicians, resources, and time. But that's no excuse. We've got to look at how we can improve with what we have. A lot of you would have heard that this is what's happening to our health service, that it's sinking. Some will say it's broken. The reality is it's probably a bit of both. But that mindset doesn't help us improve what we've got. It sort of sets in apathy. So the health service is often likened to a container ship, very difficult to change direction. But on the flip side, if you think of ophthalmology, it only probably represents a few containers on that ship. And within that, the corneal service is even smaller, and the keratoconic service is yet even smaller. So you can actually sit in one corner of your container and tweak things the way you like it. You can paint the container without the captain getting involved. So this is what we thought we'll do. I thought, what do we want to do? We want to provide each patient with all the treatment options that are available. We want to provide the correct treatment, and we want to provide it in a timely fashion. So these are obvious things. So when I started, the service was extremely busy and tight, and I thought, well, it'd be good to know what the patients want. So what I did is I surveyed 50 consecutive keratoconus patients that I saw in my clinic. Surprisingly, and I put the 4 commonest things that they wanted changed or would have liked to have seen. The key was information. A lot of patients wanted more information on the condition. I think, David, you touched on this. We're probably not that good at communicating. They wanted swift access to visual rehabilitation, swift access to treatment, so be it allergy or eye drops, and wanted, above all, to be symptom-free. So funny, what we wanted is not exactly the same as what the patients wanted. And we try and align the two. Just remembering that this place wasn't built in a day, I thought we've got to start somewhere. So the information booklet was the first place to start. And we had information on keratoconus, which is a little bit outdated. We had information on transplants, which covered all different transplants. So the first thing we did is updated that, put on information leaflets on the different types of transplants, and we now update that periodically. What we've also done is, I'm sure you'll be glad to hear, is added the Casey support group information, which wasn't there before. And we ensure that it's received by all our patients, and I'll talk about that a bit later on. So that was a relatively easier thing to do. Trying to deliver on the other fronts is a bit more challenging. So I thought what we need to do is look at how the patients access our services and what happens to them. So how many new patients are referred to us every year? How many visits do they have? Who do they see? And what happens to them? Okay. So I did a quick survey, and this is an approximate figure, and I came across about 150 new keratoconic patients sent to us every year. That's about 3 patients a week. And I looked at what happens. So the first visit could be in a corneal clinic or a general clinic, and they could see either the consultant, the associate, a junior doctor, or someone who doesn't specialize in corneal diseases. The second visit was then in a corneal clinic. So all patients in the general clinic were referred to the corneal clinic. Some of them may not have had the investigations, topography, etc., or the information given to them. So then they would come back again to the corneal clinic, either for monitoring or be sent to the optometry clinic for refraction or contact lens fitting. And either treated, observed, and rarely discharged. So we were getting 150 new patients in addition to all the patients that we already had in the system. And I found that they may not be seen in the corneal clinic in the first visit, which is not ideal. The decision or the treatment plan may not be formulated until the third visit, which again is not ideal. And if you think about the delays between each visit appointment, that could easily be a year. So we thought, how do we improve and simplify this pathway? So firstly, we designed a new code for patients that are referred for keratoconus. So when we get a referral from an optometrist or a GP, these patients would be identified with a separate code and not coded as corneal or general patients. And then we ensure that all these patients are seen by a specialist optometrist. And the optometrist would do a full clinical evaluation. And I'm sure most of you would agree that optometrists are better at doing most things than we are as doctors. So they'd have a full history, vision, refraction check for glasses or contact lenses, topography, they would have the pressures checked, a full dilated examination of the back of the eye, an optic disc OCT, so scanning of the optic disc. And this is sort of future-proofing. We know that checking the pressure in eyes that have thin corneas or have had transplants is not always accurate. If you have a transplant or you're on steroids, you're at a slightly increased risk of developing glaucoma. How do you tell that? if you have a baseline evaluation of your optic nerve, then that might help when in 5, 10, 15, or even 20 years, if there's any change, you can look back. And all patients got an information leaflet. So now we could ensure that information was going out, and this is done electronically, so we can have a record. And then all these records were checked by the consultant, in this case myself. So I would go through all the records, the referral letters, the scans, the history, and the treatment plan. And the patients were then seen in the corneal team at their second visit. So this is what the new pathway looks like. So the first visit, they're seen by a specialist optometrist. Second visit, they come to the corneal clinic, where we would assess for progression or response to treatment, and either then referred back for contact lens fitting or observed. But there's a safety net here, where anyone with an urgent problem, severe ocular surface disease, eye drops, or something unrelated, incidental findings of the back of the eye, have access to the corneal clinic on the same day or within a couple of weeks. So compare that to what we used to do, that's made a huge difference and simplified the process. I'm not pretending we're there yet, this is still work in progress. And what I envisage will happen in the future is that patients would be seen by the same specialist optometrist and the treatment plans would be instigated earlier with the support from the corneal clinic, where we've got patients who've had their transplants or are undergoing active treatment. So I did a recent audit. This was a pilot that we started in March 2016. And to date, there have been 217 new keratoconic patients seen by the specialist optometrist. All their notes have been reviewed by myself. And we found that about 10% of patients needed review on the same day. Okay. To date, about 10 patients have not attended their appointments, and that's sort of roughly in keeping with what we would expect with general appointments. The numbers there are not entirely accurate, as some of the patients have still not reached their 6-month follow-up. And we've seen about a third of patients on their second visit. And to date, there have been no safety concerns. There's been nothing missed, and there have been no serious incidents. So what this has done is it's freed up around 200 appointments in the doctor's clinic. Now, if you think that each appointment costs in the region of about £150, £200, you can do the sums. That's a huge amount of money saved, which hopefully we can pump back into the system to help improve the service further. What we've got is every patient that's been referred has a standardized and a thorough examination. They see the same person or people with the same expertise, and all the data is recorded systematically. They have an earlier review or intervention. Treatment's not delayed with this pathway. And most of you would have seen a hospital optometrist. And in this scenario, you don't wait for your third visit to see the optometrist. You start building a rapport earlier. So that was the pathway. I looked at treatment. When I got there, again, I found that most patients were being treated adequately. Perhaps could have been done with being treated earlier. That was medical treatment. Surgical treatment is where we were failing. And particularly, I looked at collagen cross-linking. At that time, patients were advised that it's not available and were referred back to the GP. And that was true because it wasn't NICE approved at the time, but it wasn't helping our patients. So what we did is I'd written to a couple of the units and said, well, if we want to refer patients to you, can you send us some referral criteria? And what we do now is monitor the patients. As soon as they meet the referral criteria, we instigate the treatment. And Dan Gore and Morphils have been very good in supporting us with that. And we send the scans with the patient letter so that patients are not going back and forth, just having the same review that they could have had locally 100 miles away. So with collagen cross-linking particularly, which is something I feel strongly about, we've referred 127 patients elsewhere. Not ideal because they've had to travel It's probably caused a bit of delay, but we've ensured that these patients have actually received the treatment, whereas they probably wouldn't have in the past or have been too late for treatment. Interestingly, over 10-15% of patients were in the age group of 18, and this is something that we're seeing increasing. Community optometrists are getting better at picking up early keratoconus. These patients are likely to progress earlier and need prompt treatment. So raising awareness has helped pick the younger age group where hopefully we can treat and stabilize early. We put a business case which is still pending and work in progress, and it's fantastic to be here because I think if we could get your support in our local units to drive a little bit of pressure to get the system in, that would be fantastic. Okay. So again, when I got there, I found that the transplants were performed outside the trust, and that was a good service, but what patients wanted was prompt treatment locally. So I put business cases and we bought some equipment, we hired some in, we used our local charities to support us and get some equipment in, and I must have been very lucky with the support that I've had. And we started providing local service, and we've done several hundred transplants to date, where patients have been treated promptly and not had to travel between different sites. And most patients are day case, they're not having prolonged hospital stays, and managed mainly on an outpatient setting. So, just to recap as to what patients wanted, I think we've achieved some of this, but not all of this, and I can't pretend that this work will ever be done. We'll have to keep revisiting and looking. That's what we want. Again, we're not there, but this is work in progress. And none of this would have been possible without the help of my colleagues. Some of you may have met them. So Judith Halliwell and Christine Wright, really experienced optometrists who sadly for me have retired. But I've got Catherine Brown, Emma Stokes, who've joined us recently, who are taking up this work and trying to drive it forward. So for the future, I'm hoping that we are able to share experiences, and forums like this are helpful where we can talk and see what other units have done and try and, if you like, copy and paste. We can collect data. When I got there, there was no data, and it's useful for me to know how many new patients come in, how many follow-ups we have, how many transplants we do, so we can try and fine-tune and provide a better, seamless service. Provide a service that's keratoconic specific. Okay. It's not ideal for patients with any condition to be grouped in a general clinic or with other patients. If you provide a specific service, then you can streamline it and you can improve it. And keep auditing our outcomes. I'm hoping to formally audit the outcomes by the end of the year. Our surgical outcomes are audited by NHS Blood and Transplant, so all surgeons and all units get a data of how we are performing, what our transplants are doing, and that's great because that allows us to tweak and improve. Patient surveys are extremely important. As I said earlier, I haven't found anything that's specific to keratoconus, but talking to one of my colleagues, Stephanie Campbell, I think this is something we can certainly look at doing in the future. And on that note, I'll be grateful if you could email your thoughts to me. As I said, this is more of a learning exercise for me. If there are experiences that you've had that you think are worth sharing, experiences that you think are not worth sharing, please drop me a line. Okay. Thank you very much.
Thank you. Thank you.